the PPS data that we looked at the other day for CML treatment-related symptoms, there was 20% of the respondents reported myelosuppression and fatigue as the ones that they needed more help in understanding and assessing. Which do you see more of in your practice, and what do you help nurses do to combat these for their patients?
Well, I think that myelosuppression is obviously very common in hematological malignancies when you initiate therapy. It's probably universal.
Right.
I found it a little surprising that that was still such a big concern. So obviously we need to do more to educate the nurses on how to manage those patients. Right. I think that in CML you see patients with myelosuppression that's really not symptomatic, and so we need to help them deliver a level of comfort with numbers, neutrophil counts and platelet counts that aren't necessarily dangerous in that population as they might be in a solid tumor patient.
I think fatigue is probably much more challenging because we don't have anything specific
to do for that. And I mentioned in my lecture yesterday that I wish I had a little fairy dust to sprinkle around to just magically make it go away, because it is a big concern. I don't think we understand it, how to quantify it, and even patients have difficulty describing it.
That's very true. Do you use a fatigue assessment tool in your practice?
We don't. There are some out there,
I've seen them,
and I think we focus more on ADLs, activities of daily living, and now they talk about instrumental activities of daily living, and so just doing the things you need to do every day: get up, get dressed, get something to eat, not even talking about going to work.
Yeah, the real basics.
So we need to do a better job at quantifying it.
Let's talk a little bit about compliance and adherence to the oral therapies, because it is such a challenge for patients and for nurses. What do you see in your practice?
Well, I think there's more and more now that's being administered orally, and in some ways it's great for the patients because they don't have to have needle sticks or IVs, and they can do it themselves at home. The challenge is that they're usually not just on one medication, and in the case of CML, there's a great quote by Sandra E. Oral drugs only work if you take them.
Right.
So if this is their therapy, taking it on a consistent basis is critical to having a good outcome. We as nurses, I think, can really help patients by understanding what else they're taking.
Yeah, good point.
Can it go with food, not with food? Do two things go together or not? In CML, drug-drug interactions are a big problem, both in terms of absorption and metabolism, but also in terms of looking at QT prolongation as one of the side effects. So there's a lot that we need to understand when these patients are on therapy, and then looking at their specific regimen and making it a doable thing for them.
Right. What about some of the health system barriers and some of those factors that influence patients' compliance with TKIs?
Well, I think we still struggle with who's covered by what insurance and who can they get their medications from, and when do they get them shipped? Can you just go down to the local pharmacy and pick it up, or does it come from a specialty pharmacy? If they're on Medicare, are they hitting the donut hole? And so there are some big challenges. Thankfully, I think there are some really good patient assistance programs in place offered by the companies that manufacture these agents, as well as other groups like the Healthwell Foundation and other things. So we need to familiarize ourselves with those assistance programs and use them.
It's interesting. One of the girls who stopped by the booth today was taking the AOCN exam on Thursday, and one of her colleagues was unsuccessful in an attempt. And one of the things that she was not familiar with were support agencies for patients, and those were the questions that she really struggled with. So I started thinking about some nurses that practice in small community centers or in private doctors' offices, how much they really know about those supportive agencies and those reimbursement departments for pharmaceutical companies that are really out there.
And I think one of the biggest problems, honestly, is with oral therapy is you're outside the safety net of nursing.
Exactly. Yeah.
And so you come in as a patient, you see your provider, you get your prescription, and you're on your way, and you may not interact at all with the nurses. unless you're getting some other additive therapy.
That's very true. Good point.
You're
Good
not
point.
upstairs in the infusion area. If you're in a private office in the community, you may never see the nurse. And so if you take a disease like CML, well, where we have gotten away from interferon and all the therapies are oral, those nurses may have very little contact with those patients, and you don't develop that same level of rapport and getting to know them and their personal situations. And so somehow we have to fill that gap.
Do you think up front patients should be told about some of the resistance issues with the TKIs? And if so, what do we tell them?
I'm not sure we honestly understand it very well ourselves. So I think it's difficult to explain that to a patient. And I think I think they need to understand that if whatever it is we start with doesn't work, we have additional choices. But beyond that, I'm not sure they need to live with the fear that this is
It may not work.
stop working for them sooner than later, and really focusing more on managing their side effects and getting them through that therapy effectively in the first part of their treatments.
Good point. How is the nursing shortage affecting your practice?
I think that we don't really have a shortage per se. I think what we are seeing probably more now is a difference in who's becoming a nurse. So we have a lot, or more specifically an oncology nurse. So we have a lot of staff, and this is a big challenge for educational providers. We have a lot of staff who have come to us from the GI lab, from the OR, from peds, and they suddenly want to do oncology, and they get sort of bit by the bug, if you will.
Yeah.
And they love it because it's very special, and you get a passion for what you do, and they like the continuity and being involved with patients. But there's a huge learning curve, and learning how to treat, or teach rather, that new group of nurses how to become oncology nurses.
Big challenge, right.
And I think at the level of an NP or a PA, it's even more of a challenge because we have people coming through nursing school to be advanced practice people in oncology with no oncology experience.
No foundation.
And that's, I think, even more challenging.
So what do we do to make sure that all of the nurses walking around here as first-time attendees at Congress are still in the oncology workforce next year?
I think that we need to share with them our passion for what we do, that it's really a very special area. We're incredibly lucky as a group of nurses to have the support we have with, programs like Imer and the educational materials that are available to us, the publications that are available to us. I don't think there's any other subspecialty. Perhaps critical care nursing is the only other thing I can think of that has that kind of camaraderie and support. And we just need to invite them in and share our joy.
Very true.
Even though it's challenging at times.
At times.